past 6-7 years. So when we are looking at the system, it's very simple to use. It's almost like a thermometer. Now what we understand with a thermometer is how patient's temperature varies. Similar to that, we look at the breast tissue, see how the temperature varies in the breast tissue, and we are able to accurately predict how the variation is captured. So when you look at it, so the first and foremost, infrared thermography has been there for many years. So it's not something that we have brought across. It's been there for as old as the X-ray systems. The fundamental way that we have done the acquisition of temperature is the differential way that we have acquired the temperature actually helps us to isolate the clinical areas, amplify the tissue changes, and make sure the diagnosis is perfect. So we have an accuracy which is 97% of over 5,000 patients, and these are done at 6 different institutes. So it's not that we have done it in one institute and we have taken up the data shown across. So what do we talk about in this case is we actually measure the physiological data. That means what happens, the first thing when you have a disease is your temperature varies. So that's what a thermometer tells you. Similar to that, the physiological data here, that means if the blood vessels or any of those are able to carry some of the information, they are able to detect much early, very early as such. We'll show some of those data out here. Since we don't do any radiation, since we don't do any injection, it can be done for all patients of all ages out there. And we also, one of the issues of X-ray mammography has been dense breast. Typically in countries like India, women have more dense breast than elsewhere, which is statistical data which is there. So we do not have the issue of dense breast issues which are there with X-ray mammography. With X-ray mammography, when you add dense breast, the what you call it about the accuracy, clinical accuracy drops below 70%, significantly below 70%. We don't have such issues here. We are also talking about like what Bala talked about. We said there should not be any pain. So that means we can't compress the breast, we can't do any of what the other modalities do. We are not talking about touching the patient, which is because one other thing is breast is the most sensitive part of a woman. So if an external person wants to touch it, it creates a lot of fear. It also creates a lot of changes in them. Then the exposure of breast. So what happens is that you could see the design. The patient does not expose themselves in front of any new person out there. We are also talking about non-invasive in the sense there is no, we don't send any drug or anything to amplify those changes in the tissue. So it's pretty safe. So women of all ages could be done, and it is repeatable. Since we read only the temperature map from the breast skin, it can be repeated n number of times. There is no restriction. Today, if you do an X-ray mammography, you are not supposed to subject the patient again to X-ray mammography within 6 months until it is clinically required. In MR mammography, you are subjecting the patient to some sort of contrast to amplify the changes. So you can't do the patient again within a quick span if you want to repeat. So these are the highlights which I have talked about. So in the various slides, so that's captured here. So when we're talking about what are we talking about? We have been able to detect at sub-millimeter, that's 0.2 sub-millimeter point of it. That's around 0.2 mm. We have been able to detect changes which are there. And since we acquire the breast tissue, the images in a fashion which is similar to ultrasound. So you have the ultrasound clock position, which is what most scanning sonologists do. We acquire in a similar fashion. We help them to reduce the time when there is a follow-up to be done with ultrasound by significantly reduce the time by 44% because they can localize, they will know from which area they need to put their ultrasound probe and look at those areas out there. So what are we talking about? We're talking about how do we ensure that there is a screening. Today, when you're talking about screening, you're talking about self-exam. These are the various steps which are followed. Then you have ultrasound mammography, ultrasound sonography. Then you have X-ray mammography, MRI. Then there is a confirmation which is done with biopsy out there. But all of this, once from ultrasound screening onwards, these are anatomical changes that is structural changes which are required, which is captured, and then a biopsy is performed. So we are talking about being done before. Self-exam has not been very accurate. Internationally, self-exams have been proven as such that it is very subjective. It's not possible for a woman who is under stress to clearly examine herself very objectively. But once a palpable lesion is captured, then they go to a gynecologist for there, then the whole process starts out there. So we are talking about doing it much earlier in this case. We are also talking about from a point of view which is in therapy. That means today a patient who has undergone what is called as a cancer, which is an adjuvant chemotherapy, or patients who have undergone partial mastectomy or partial breast resection in one breast. There is a risk for them to be evaluated very often. So the same patient who already has a cancer is subjected to X-ray mammography repeatedly to ensure that the risk is not seen much more. So we are trying to bring in this modality to ensure that you can clearly monitor whether the adjuvant chemotherapy drugs are working very well, or there has to be a course correction in the way that the treatment happens to the patient. And you can follow that up once it is detected with X-ray mammography or with the biopsy systems which could be done. So we are completely changing the way that the radiation portion of it we are trying to reduce for these patients. So how does it work? So we take 360-degree view of the breast. So if you look at it from that point of view, so the patient lies on a prone position with the breast alone being exposed to the infrared camera, and then the infrared camera is able to do 360-degree view of the breast. So right from the chest wall up to the nipple, we are able to cover it in one portion, in one angulation. We move the camera with a robotic arm for 360 degrees. Now the best part of it is that this is completely automatic. The degree of acquisition in terms of how it has to be done, the user has a control. So that could be changed. So we also have a software that is a full-fledged workstation that will read this information and will be able to pinpoint those areas which have high temperature. So we have a temperature map which is completely shown on the side, where the doctor could understand how the temperature variation happens across from the nipple to the chest wall. So the prone position, when we were explaining to you as such, what happens in this case, in this particular case, is that the infrared information from the other part of the body is completely isolated. So you don't get infrared information from the chest walls or from the cardiac muscles or from the abdominal area, and also from the other breast. So we study only the breast tissue in this particular scenario. And what does it also show is that there is an inbuilt air conditioning system. So the temperature is completely monitored, in the sense that we are able to recreate the same environment when for the breast. We change the temperature to a lower degree and see how the tissue responds to the change in this temperature. Now breast is a vascular structure, so it will immediately react to the change in temperature. So this change in temperature, if it is uniform, we can understand how the diagnosis will happen. If it is non-uniform, it will amplify those areas which we need to focus on. So how does it compare with the modalities which are currently available? This is a snapshot of what things would do. You have MRI, ultrasound, X-ray mammography, as well as the Illumina 360. So effectively, if you look at it from the time taken part of it, that's more or less similar. Positioning part of it, MRI scanners as well as Illumina 360 degree, we are talking about prone position. X-ray is done on an erect, standing posture, and ultrasound is on supine position. You would require certain changes in all these systems to do, whereas in Illumina 360 you don't require anything specific. There is no injection, there is no contrast injection out there. In ultrasound, you still have a touch of a probe which goes and touches the patient. In X-ray mammography, like what Bala had talked about, is about compression, which we are talking about. And patients who have tender mass, they react much more differently. And there is an exclusion criteria, which is childbearing age. So up to the age of 40, until unless it is clinically required, you don't screen them at all. So, and the scan repetition, there is no issue of scan repetition. As many times you could call the patient and do that. Now, this temperature map is like a signature of the patient, which could be stored and can be recreated for subsequent visits for those patients. So, we will show some of those clinical data that shows how we have been able to recreate and pinpoint those parts. So, these are the participating hospitals which has helped us out to reach out to 5,000 plus patients. So, we have Raipeta doing a lot of cancer patients which we have worked on. Madurai Rajaji General Hospital has helped us out. The Rajiv Gandhi General Hospital, which is the Institute of Radiology, Bernard Institute of Radiology, has been part of the study. Stanley Medical College and the GMC in Nagpur. So this is the award that we received from the Government of India out there. We are proud about the US, not about the US patent, we are more proud about it because this is an idea that we talked about, we were able to take it upon ourselves, then also not only the patent validated our design as an innovation, also able to commercially bring it across as well as have the clinical data to support it. So we have the CE certification, so it's now ready to go to the market, so we are looking at commercial launch also. Thank you. I invite Dr. Sandeep to talk about the clinical part. Thank you.